The traumatic intracerebral hemorrhage can be very confusing at times clinically because it has a lucid interval. Now, lucid interval is sometimes when you're going to suggest that I had a heavy blow and it has internal damage. Vomiting, nausea, headache, all these symptoms can basically correlate, or dizziness can be a part of symptoms that are going to indicate that there was severe internal damage relating to the trauma that you had. So basically, this is very confusing and it is very tricky at times clinically when you are dealing with such patients. Now we can have the primary brainstem hemorrhage, and as basically it is dealing with the intervertebral artery and what are the areas that were prone. For example, the most prone area is the first cervical vertebra that is basically going to cause this primary brainstem hemorrhage. Then we have the coup and the contact injuries, and how are we going to deal with these coup and contact injuries clinically. Then we have the concussions, the cerebral edema, and the secondary brainstem injuries or the lesions as well. And we are going to discuss all of these things in detail in this final section. How are we going to clinically modulate such patients? Now, a well-circumcised lesion, sometimes rounded, which lies laterally in the tegmentum, the shape of the midbrain being undistorted, is regarded as the primary brainstem hemorrhage, as seen over here. So it's basically clinically, the only diagnostic feature that we have are the CTs and the MRIs that come very handy whenever we have some sort of confusion or the symptoms are not quite there due to the lucid interval, because the lucid interval can have varied amounts in different patients. It's not definite that this is 1 hour or 2 hours the lucid interval. It can vary according to the patient and according to the trauma that he had. Now, the typical site between the aqueduct and the outer end of the substantia nigra is the mainstay over here, and usually it is associated with the occipital impacts. So the occipital regions, the frontal regions, obviously, the temporoparietal regions, they're all involved in the brain stems, but the occipital regions are specifically involved in the brainstem hemorrhages because due to the gravitational forces, the blood tend to accumulate in these occipital lower regions. Now, then we have the coup and the contact injuries. Now, the coup is basically, it is a very quite comprehensive diagram. Whenever we had a head impact, the brain damaged at the site of impact, it's basically known as the coup injury. And when the brain goes back towards the backer portions, towards the posterior portions, the injury to the brain, which is basically contralateral to the site of impact, it is known as the contact injury. So basically, coup is at the site of impact, and the injury contralateral to the site of impact is known as the contact injury. And it happens because the blood is bathed in a fluid, and whenever you'll hit your head hard enough, it's basically going to have a back and forth motion. So even at the site of impact there is going to be an injury, and even at the site contralaterally you'll have some sort of injury. So these are known as the coup and the contact injuries, and they have their own implications. Most common site for the contact injuries are the frontal and the temporal lobes. In temporal and the parietal compacts, the contact lesions diametrically opposite on the contralateral surfaces. And a fall on the frontal region produces an occipital contact injury. So we'll have a frontal coup and we'll have an occipital contact injury in these cases. So in a temporal impact, the contact damage on opposite side of the ipsilateral hemisphere from the impact against the falx cerebri, that is basically contributing towards the contact injuries. The degree of the contact damage is more, and the force may be sufficient to fracture thin bones of the floor of the interior fossa. Now, then we have the concussions. Concussions are again very important. A transient paralytic state due to the head injury, which is of instantaneous onset, doesn't show any evidence of structural cerebral injury and is always followed by amnesia. The amnesia is basically referring towards the loss of memory. So, loss of memory is part of the concussions from the actual movements of the accidents. So, we can have even amnesia, vomiting, headache, dizziness. These are the symptoms that are going to correlate towards the type of damage the person had after the traumatic injury. The common features are the rapid onset of the usual short-lived neurological impairment, and then we have the acute clinical symptoms as well. A range of clinical symptoms that may or may not involve the loss of consciousness. Then we have the diffuse neuronal or the axonal injury. So we have to differentiate between these injuries. The axonal injury is basically a non-specific term referring to damage to the axons of any etiology. Then we have the traumatic axonal injuries. It is a damage to the axons caused by the trauma, which may vary from small foci of axons to more widespread damages. These are basically the diffuse TAIs and is most severe form of the traumatic axonal damage. Then moving on, we have the diffuse axonal injuries as well. That basically correlates with the first described as a clinico-pathological syndrome of widespread axonal damage throughout the brain, including the brainstem. And that may be caused by a lot of other pathological processes. For example, it can be fractures, it can be blood dyscrasias, or any thrombus formations, etc. Now, the cerebral edema. Moving on to the cerebral edema. It can be detected even at the post-mortem, and it has a lot of types. Basically, these are the types that are shown over here. We have the vasogenic, the hydrostatic, the cytotoxic, osmotic, and the hydrocephalic types. Dealing with the edematous location relating to these types is the extracellular white matter in the vasogenic type, and the blood-brain barrier permeability is increased in such type. The increased permeability of the vessel wall, and the clinical situation can be a tumor, trauma, infection, abscess, or ICH or infection. So all of these are causes of the vasogenic type of the cerebral edema. Edema is basically a collection of the fluid in the cerebral space extracellularly, and that is basically, it has all of these causes. So the hydrostatic edema can be obviously the permeability is going to be increased, and the extracellular white and gray matter is the location that is highlighted in the hydrostatic edema. The mechanism involved is the increased blood pressure, and the clinical situation can be hypertensive, encephalopathy, or epileptic seizures. Now, while we are dealing with the cytotoxic type of edema, the location is usually intracellularly or the gray matter. The blood-brain barrier permeability is not increased in such a case, and the mechanism involved is again the lack of energy or toxic influence leads to the malfunction of the sodium-potassium ATPase pump. The clinical situation can be hypoxia, ischemia, Rice syndrome, and some intoxications. For example, cyanide poisoning is a highlight to these cytotoxic type of cerebral edemas. Then we have the osmotic edemas. Now, regarding the osmotic edemas, they can be intra or extracellular white or gray matters can be involved. The blood-brain barrier permeability is not affected in such a case, and the mechanism involved is the hypoosmolarity of the plasma that will basically result in the extravasation of the fluid. The clinical situations again can be hyponatremia, excessive infusion therapies, water intoxication, or freshwater drowning is another cause of this osmotic type of edema. Then we have hydrocephalic type of edema, which is basically extracellular periventricular white matter is involved in such cases. The blood-brain barrier permeability is not affected again in these cases. The mechanism involved is the leakage of the pressurized liquor into the periventricular brain tissue, and the clinical situations can be high pressure, hydrocephalus, and pseudotumor cerebri. So these are basically the summarizations of the causes of the cerebral edema. Now, basically it has its own forensic implications. What are going to be the forensic or the autopsy features of the cerebral edema? The dura is going to be stretched on autopsy findings, and it is going to be tensor. The brain is bulging through the first incision in the membrane. The gyri are pale and flattened, and the sulci are filled, giving normally corrugated cerebral surfaces or smoothness. So these are basically the autopsy features that we are going to look out whenever we are going to have a suspicion of cerebral edema. On the cut surface, it is going to be paler and the ventricles will be reduced to slits. Now, the diagnosis of the early cerebral hypoxia or ischemia. The stage 1, we will have the microvacuolation seen in 2 to 4 hours, and the cell outline remains smooth in such cases. Slight eosinophilia and microvacuolar changes last for only a short period of time. In the second stage of hypoxia, what happens is there is more prolonged hypoxia, so it is going to distort the shape of the neurons. The cell body is shrunken, the nicelle granules are more finer, they are dispersed more widely throughout the cells, and the nucleolus becomes obscured, nucleus is dense and pycnotic in nature. In stage 3 of ischemia, the ischemic cell stage becomes worsened. The cell shrinks, the eosinophilia and the blueness, when stained, it persists, and small spherical or irregular bodies begin to adhere. The dark shrunken nucleus is present, and polymorphonuclear neutrophils accumulate by 15 to 20 hours in the lumina. In stage 4, there is homogenization of the cell and is best seen in the Purkinje cells. Nucleus stays dark and triangular until vanishes. It leaves a pale ghost-like appearance due to the vague perimetry. Blood derived in the monocytes and the phagocyte, it appears in about 2 to 3 days, and it begins phagocytosis of the cell debris. So this is basically different stages of the hypoxia seen at a cellular level. The secondary brainstem lesions include the secondary hemorrhages, focal brainstem infarcts from the vascular compromisations. Distortion, compression, and rotation of the brainstem can result in the secondary brainstem lesions. Then we have the pressure necrosis from the transtentorial herniation. So obviously if there is a trauma, there can be some sort of herniations through the foraminas. And the diffuse hypoxic anoxic ischemic injury is also part of the secondary brainstem lesions. So in this section, we dealt with the brainstem lesions and the brainstem trauma in detail. That was the end to this section. Thank you for watching sqadia.com.